Thank you, SASPI, for giving us this opportunity to share our thoughts regarding these things. So I'm going to talk briefly about community-acquired pneumonia. My presentation is very, very simple, and I think it's difficult to talk after Dr. Anita's talk. So maybe go to the next slide. So I'm going to share some cases and then take cues from that to discuss the main elements of community-acquired pneumonia diagnosis and management. And I like this quote by Sir William Osler, who said that he who studies medicine without books sails an uncharted sea, but he who studies medicine without patients does not go to the sea at all. So next one, our first patient, next slide, please. So this, our first patient is a young male who had presented with backache, type 2 diabetes, morbid obesity, lichen planus, suspected OSA. He had come one night to the emergency with 1 to 2 days history of severe backache, along with some fever and cough. Very sketchy history. He was prescribed NSAIDs for muscular pain and asked to come for follow-up in the OPD. Next slide. So he was brought back 2 days later again to the emergency with shortness of breath, worsening fever, worsening cough, and chest pain, which would increase on breathing. He was tachycardic and tachypneic at this second presentation with saturation of 93% on 3 liters oxygen. Blood pressure was maintained, but he had bilateral basal crepitations more on the right side, and there was bronchial bleeding in the right infrascapular region. His blood gas showed that he was hypoxemic and had compensated metabolic acidosis. He was diagnosed to be having severe CAP, admitted in medical ICU. We started him on amoxiclav and clarithromycin. He required non-invasive ventilation and went on to require invasive ventilation subsequently. Next one. So he continued to deteriorate, remained tachypneic, febrile. HRCT showed necrotizing pneumonia. I don't have this, but I have this chest X-ray which was done subsequently, which shows bilateral patchy consolidation with areas of breakdown. So his antibiotic, looking at this, was escalated to piperacillin, tazobactam, and teicoplanin. His sputum culture subsequently was reported positive for methicillin-resistant Staph aureus. He continued to worsen, developed shock, liver, renal dysfunction. And so this was a patient who had presented initially with very minimal symptoms and then went on to deteriorate to a fatal community-acquired pneumonia. Next one, please. So we cannot diagnose what we do not suspect. So the first dictum would be to suspect CAP and the early setting, in the OPD setting where possible, because it would be very, very less likely that the patient directly comes to the emergency. Usually the patient sees somebody in the OPD setting and then does not improve and then lands up to become what we call as an ICU pneumonia. Next one. So what are the symptoms of CAP? The initial symptoms, early symptoms are just very, if we look at this first slide, they're just local inflammatory response that we see. So cough, sputum production, maybe shortness of breath, pleuritic chest pain, tachypnea, dullness on examination on percussion, rales, hypoxemia, pulmonary infiltrate. So these are the early signs and symptoms. And then when the systemic inflammatory response sets in, then we see what we see, the other features sort of come in. And if it continues, then we see organ involvement in terms of confusion, in terms of the leukocytosis that we see, or the thrombocytopenia that sets in. So these happen later down in the line, not on day 1 or day 2 of the patient developing CAP. So first step, local, and then systemic inflammatory response, and then we go on to develop organ dysfunction. Next one. So this brings us to our second patient. He's 65 years old female with fever and male with fever and cough. He had history of hypertension, fever of 5 days duration, which was up to 102 degrees Fahrenheit, associated cough and diarrhea. He had bilateral basal crepitations. The pulse rate, respiratory rate were normal. Saturation was 99% room air. So this and the hemodynamics were okay. Initial working diagnosis was influenza-like illness category B, keeping in mind his age and comorbidities. Initial labs, though, showed like leukocytosis, significantly high CRP. So and his CURB-65 score was 1. So it was more of probable viral pneumonia with superadded bacterial superinfection. We started him on cefuroxime and recommended HRCT chest and testing for influenza also. Next one, please. For financial reasons, in fact, the patient did not get the influenza tested, though he did come back later with his HRCT report. Next slide. Can we go to the next one, please? Yeah. So here we see on day 5 when he came back, his symptoms were better. His saturation, though, was slightly lower than what we had seen on the day 1. And the CT showed these patchy ground glassing opacity in bilateral lung fields, left lower and the right mid-zone region. Next one. So by day 7, he had still had minimal cough, but other symptoms had settled. His cefuroxime was stopped, and we had recommended influenza and pneumococcal vaccination to him down the line. The question here is that while going through this case, I was questioning myself as to could I have stopped the antimicrobials on day 5 in this particular patient instead of day 7? So that's an open question. Next one. Briefly talking about the pneumonia severity scoring, CURB-65 is what we commonly use in the OPD setting to identify those patients who can be managed in the OPD vis-a-vis those for whom we need to recommend admission. 5 parameters are looked at, and each parameter, if present, gets 1 point. So the C in CURB stands for new onset confusion, blood urea nitrogen, U for blood urea nitrogen more than 19 milligrams per deciliter, R for respiratory rate more than 30 breaths per minute, and B for the blood pressure, systolic less than 90 or diastolic less than 60, and 65 for the age more than 65 years. So our patient had a CURB-65 score of 1. Score of 0 to 1 has a relatively low mortality, and this patient can be managed in the OPD setting. CURB-65 of 2 means that usually an inpatient admission is recommended to these patients because they have almost 9% 30-day mortality. And a CURB-65 score of 3 to 5 has a high mortality to the tune of 15 to 40%, and therefore they definitely need admission, and preferably in the ICU setting. Next one. So next. Yeah. So what are the pathogens that are commonly responsible for community-acquired pneumonia? So these are the ones which are more often the causative agents: Strep pneumoniae, Strep pyogenes, the methicillin-susceptible Staph aureus, and in terms of gram-negative, the H. influenzae, Moraxella catarrhalis, and we are seeing Klebsiella also, obviously, now. And in terms of atypical bacteria, Legionella, Mycoplasma, and Chlamydia are the main, Chlamydophila now called, are the main ones. And respiratory viruses, influenza, and SARS-CoV-2 are the main, but the other ones are also commonly seen when we sort of do the biofires here. So definitive microbiologic testing is usually neither feasible, not recommended for the low risk caps. So if the CURB-65 is 0 or 1, we will not be doing any microbiologic testing for most of these patients, and empirical treatment is therefore the norm in this subset. Next one. These are the uncommon causes of community-acquired pneumonia. We need to have a very good history to be able to sort of suspect them, and they will be tested for if suspected. Usually, they are neither tested nor treated if the significant risk factors for them are not present. Like I would think of a MRSA pneumonia if a patient has significant skin lesions. The first patient that I mentioned had lichen planus, and that had infected lesions. So we could have suspected that earlier. Either a beta-lactam or doxycycline or macrolide. For the OPD setting, this should suffice, and this will cover all our major bacterial and atypical organisms. If patient has significant comorbidities, we may give two of them together. You may give a beta-lactam along with doxycycline or a macrolide. The fluoroquinolones, though they are recommended in ITSA, they are not recommended in the Indian context. The ICMR very strongly says that we should not be using it in the Indian context because of we would like to preserve this class of drugs for our TB patients. Next one. Coming to the third patient, 52 years old lady with dry cough, fever, and shortness of breath. She had primary hypothyroidism and bronchial asthma in the background, obstructive sleep apnea also, and osteoarthritis of the knee joint. She presented in February this year with 5 days history of cough, associated sore throat, and fever, again for 5 days, high grade with chills, and shortness of breath for about 4 days. At presentation, she was conscious, but her pulse rate was 120, her respiratory rate was 30 per minute, her SATs were like quite low, 89% on 15 liters, though her blood pressure was okay. There was bilateral expiratory wheeze present, and her blood gas showed that she had acute and chronic respiratory acidosis with pH of 7.33, PCO2 of 62, PO2 of 52, and bicarb of 32. I need not even calculate the CURB 65 score for this patient because this very obviously this patient needs admission. Next slide, please. So this was her X-ray. So this was a classical severe multilobar cap in the influenza season, and obviously one influenza was high on the cards here. We started her on ceftriaxone, clarithromycin, oseltamivir, hydrocortisone, bronchodilators, initiated an HFNC and NIV, and a nasopharyngeal swab was sent for respiratory panel, and a chest CT was planned. Next slide. So this patient had a severe CAP in view of her need for ventilatory support. So severe CAP is diagnosed when the patient has one major criteria or 3 or more minor criteria. So septic shock, treated with vasopressors, and invasive ventilatory support are the 2 major criteria. And minor criteria, as you can see, they are multiple. So in this context, in the setting of severe CAP, many studies have shown that it is justified to give steroids, and the standard dictum of giving ceftriaxone plus a macrolide was justified, and same with oseltamivir, since our possibility of influenza was very high. Next one. And her the multiplex PCR panel did show that she had influenza H1N1, the 2009 strain, and her other labs were showing that her leukocyte count was slightly elevated, normal platelets, normal pancreat, slightly high CRP, and pro-BNP. She was shifted to the isolation room because of this. Next one, please. But she thankfully continued to improve day on day. Antibiotics and antivirals were stopped on day 5, and she was discharged on day 6 on room air. Next one. So when to suspect viral pneumonia. So when the influenza virus is circulating in the community and the patient's history is suggested very strongly of ILI, chest X-rays showing bilateral GGOs. So these are the settings where we should look for influenza specifically because the treatment modality is different, the isolation precautions are different, and otherwise if we do not treat early on with the antivirals, these are the patients that we will end up losing. So apart from that, a blanket testing for everybody would obviously not be recommended because again, one, this test is costly, and second, it won't serve much purpose in that case. But mind you, without testing, most of the viral pneumonias, they look practically the same in terms of their clinical presentation and in terms of their radiology. So without specifically testing for influenza, we will not be able to say that does this patient has influenza or any other viral pneumonia. And oseltamivir will not work for the other viral pneumonias. So a clinical picture of viral pneumonia alone, though we are justified in starting on this oseltamivir, but we will obviously be stopping if that is not proven and continuing in case it is proven. Empirical oseltamivir, again, we would not like to be giving for all viral pneumonias. We would be risking it becoming not useful in the times to come. And obviously the toxicity issues also. Next one. Could our patients, the antibiotics be stopped early on? We stopped the antibiotics on day 5, but could we have stopped the ceftriaxone and clarithromycin once we saw the positive influenza report? So this is a rough guideline as to what we possibly can do for a routine for a patient. So look at the microbiologic workup. If there is no evidence of a bacterial infection, you can afford to, that's the first thing that you do. You continue therapy if there is no bacterial. Let me just run through this. So first is look at the microbiologic workup. If there's a viral pathogen identified, and the next we look at the radio. I mean, in our patient, she had blotchy large shadows and she had a very high CRP and PCT. So that was the logic of continuing the antimicrobials till day 5. Otherwise, in the setting where your other markers are negative and it is classical viral pneumonia, with the X-ray picture also showing bilateral GGOs only, you maybe can take the risk of stopping the antibiotics early on. Next one. Briefly about atypical pneumonias, chlamydia, legionella, and mycoplasma are the 3 main ones. These patients have more symptoms than signs. It is difficult to diagnose with conventional methods, and therefore they are empirically covered in the management of all community-acquired pneumonias. Lately, we are picking them up more frequently with the advent of rapid molecular diagnostic assays. Next one. So this was a patient of Legionella pneumonia that we picked up. So these shadows are usually bilateral but not symmetrical, and the patient had almost a clear chest. So the symptoms are more than what you hear on auscultation in these patients. So those are the 2 things that make us suspect. But again, if the patient has a low severity, you treat anyways, and if the patient has high severity, you anyways give the atypical cover to these patients. Next one. Just briefly, I would like to talk about these 2, the multiplex PCR panels that we have. One is a respiratory panel and one is the pneumonia panel. Legionella is not tested for in the respiratory panel. Here we send the nasopharyngeal swab. So if you're actually suspecting an atypical pneumonia, then sending the pneumonia panel would be important to be able to pick up all these 3, because Legionella is going to be missed if we are not looking at the pneumonia panel. Otherwise, the nasopharyngeal swab, the respiratory panel has more of viruses, as we can see here, and very few bacteria that are tested, unlike in the pneumonia panel, where there's a long list of bacterial pathogens that are tested for, and especially the ones which are seen in immunocompromised patients, or when we spoke about MRSA or Pseudomonas. These are the ones that are going to be picked up in the pneumonia panel. Next one. Brief this thing about when to give anything beyond the usual recommendations for CAP. So when you suspect, the first thing that you do is see if your patient has risk factors for Pseudomonas. And usually that would amount to looking for if there's any evidence of structural lung disease. If there is no evidence of structural lung disease, probably Pseudomonas is not going to be the culprit. You look for risk factors of MRSA. And here, skin lesions would be important to look for, and the patient has any other lesions, element of empyema. or clear-cut necrotizing pneumonia. So these are the patients here where you will cover empirically for MRSA. Otherwise, you will not cover for any of these additional bugs. That means that patient is in group 1, where we will be giving beta-lactam plus either doxycycline or a macrolide. Group 2, we can add on a MRSA cover to that. And if the patient has the risk factors for Pseudomonas, again, look for MRSA again. And if the patient has risk factors for both, these are the patients where we will be giving a higher BLBLI plus an anti-MRSA cover. And otherwise, only piperacillin tazobactam or cefepime ceftazidime would be able to cover for Pseudomonas. Next one. So certain key points are that for community-acquired pneumonia, especially in the OPD setting, there is hardly any role of routine microbiologic testing, except for specifically testing for influenza if your patient is in category B or C. Diagnosis of community-acquired pneumonia is based on the basis of compatible symptoms and signs, and if there's evidence, plus with an evidence of new infiltrate in the imaging study. Most outpatients with mild CAP can be treated empirically without diagnostic testing for bacteria, except for obviously SARS-CoV and influenza, as I mentioned. And for admitted patient, a comprehensive approach for testing is usually needed. We should ensure if we are sending the sputum sample, the quality of sputum is something that we need to ensure is optimal, is adequate. And even if the quality of sputum is adequate, the possibility of picking up an organism in sputum culture in a patient of CAP is very, very low. The yield is very low. So that probably might not help us. And anyways, I mean, at least in our hospital protocol, the recommendations are that we should be sending a blood culture also, because we have seen in instances where the blood culture has picked up strep pneumonia, whereas the sputum could not do that. But then still, it is important to send the blood culture in that setting. And the choice would vary of antimicrobials for CAP would depend upon the severity, as I just mentioned. If you're suspecting other organisms, we will add the higher end BLIs, but otherwise for standard patients where none of these are suspected, routine BLI plus beta-lactam, plus doxycycline or macrolide would be sufficient. Next one. So briefly, there is an upcoming role of a lung ultrasound focus in the diagnosis of CAP, especially for the admitted patients. And this is, as a non-invasive test, can be very, very helpful and can be add-on to the X-ray methodology when available. I will not run through these slides, but just briefly for those who are interested, this one is the normal one. Here, these lines, the vertical lines that we see are the B lines, which suggest that there are some artifacts because of the fluid collection there. This is what suggests the consolidation. And here, the black part in the D element, the black part is the fluid, and this flappy thing that you see underneath is the consolidated lung. Next one. So lastly, talking about the duration. So more and more studies are now coming in that for CAP, which is managed on the OPD basis, 3 to 5 days treatment would be enough. And for inpatients, up to 7 days is needed. In these particular meta-analysis, the first one in the pediatric setting, they were giving for 3 to 5 days and showing that to be adequate. So usually for admitted patients, up to 7 days is what most of the studies are now showing that should suffice even for the sickest of our patients. And like we saw in our patient also, she was critical, she had severe CAP, and 5 days of treatment were sufficient for her. Next one, please. And this is as a recent study that has been published from Indian hospitals, about 16 hospitals, and they looked at that almost 40% of the patients with viral pneumonias required ICU admission, and almost 1 in 7 had influenza or RSV. The influenza was very, very common to the tune of almost, I think, 20% of all viral pneumonias had influenza. So the carry home from this study was that these are all preventable pneumonias. These were patients above the age of 60 years, and where the morbidity because of influenza was significant, with the death rate of to the tune of 15% out of the total who required ICU admission. So there's a strong role for influenza, pneumococcal, and maybe down the line RSV vaccination in our context too. And as of now, only about 1% of the patients who need influenza vaccination are receiving it. So vaccination is one way in which we can probably prevent many of these pneumonias who require ICU admission. Next one. So carry homes would be that we need to suspect it early on so that we are able to pick it up in the as an OPD cap rather than that requiring admission. For diagnosis, it is more of a clinical diagnosis plus radiology, and only in some settings is microbiology going to be helpful for diagnosis of CAP. We need to risk stratify our patients so that we are able to manage them in the appropriate setting. Our choice of antimicrobials needs to be appropriate. OPD patients can be managed with a single antibiotic. Those requiring admission, we need dual, we'll give a dual cover with a beta-lactam plus macrolide or doxycycline, and then we can afford to stop it at about 5 days. So about 5 days for OP and about 7 days for admitted patients, and we need to prevent CAP where possible. I think that's all from my side. I'll be happy to answer questions if any.